Hi, I'm so delighted to meet you in the program of JIP's Ward Rounds. Let us move to the case study proper. 39 years old male patient presented with hypokalemia which occurred following surgery done to relieve intestinal obstruction. Despite correction of hypokalemia with injection KCl, patient continues to have severe depletion of potassium. What would be the latest electrolyte profile? Let us see. Serum sodium 133 milliequivalent, potassium 2.6 milliequivalent, bicarbonate 24 milliequivalent and chloride 98 milliequivalent. So why we are worrying so much about serum potassium? You know very well that serum potassium is responsible for a normal functioning neuromuscular junction. So in fact, our muscle badly requires serum potassium. So basically, three types of muscle which badly requires serum potassium. One, our cardiac muscle. Second one, so-called smooth muscle. That is the one responsible for all our gut and intestine. And another one is striated muscle or otherwise called skeletal muscles. So when potassium is depleted, all the three types of muscles can be affected, resulting in arrhythmias in the case of cardiac muscle and paralytic ileus in the case of smooth muscle, and you may develop all the four limb paralysis, otherwise called quadriplegia, secondary to hypokalemia. Then apart from that, hypokalemia can induce diabetes insipidus, and especially those who have cirrhosis of liver, if they have persistent hypokalemia, that can precipitate hepatic encephalopathy. So these are the consequences of hypokalemia. It can produce starting from arrhythmias to worsening of hepatic encephalopathy. So this patient definitely has hypokalemia, for which patient is being given potassium chloride, but despite giving potassium chloride, patient doesn't improve. So what would be the treatment? So generally when you have hypokalemia, so we have options of giving oral potassium supplementation to IV potassium replacement. But we always stage the hypokalemia based upon the severity. For example, normal potassium level is 3.5 milliequivalent. When you have potassium level between 3 to 3.5 milliequivalent, we say mild hypokalemia. 2.5 to 3 milliequivalent, we say moderate hypokalemia. Less than 2.5, we say severe hypokalemia. But generally, when somebody has above 3 milliequivalent, we used to give oral supplementation. But what you have to remember that the potassium is 90% of your potassium is sequestrated within the cells. So all the potassiums are present intracellularly. In the plasma, only 10% of our total body potassium is present. Okay, that you have to remember. But we assess only plasma potassium level. On the other hand, 90% of potassium is present within the cells. So generally how you can correlate? They say when you have depletion of plasma potassium 0.1 milliequivalent, that is equal to almost depletion of 30 milliequivalent of total body potassium. So in that way, if somebody loses 1 milliequivalent of potassium in the plasma, that is equal to 300 to 400 depletion of total body potassium. So in that way, it is you can say even 0.1 milliequivalent of potassium equal to 30 milliequivalent of total body potassium. So that's why when somebody has even 0.5 milliequivalent of potassium depletion in the plasma, you have to replace 40 to 80 milliequivalent of potassium either orally or IV. But generally, if somebody has mild hypokalemia, say 3 to 3.5, you can give potassium chloride solution as an oral form. But even mild hypokalemia can be treated with diet intake as well. But what you have to remember that most of the dietary products, most of the vegetables and fruits which contain potassium, that is present along with phosphate. So the absorption of potassium from the dietary product is very, very minimal. That's why we always rely on the oral potassium supplementation. When somebody has below 3, then you have to give IV potassium. But what you have to remember that those who have cardiac problem or those who have cardiac ischemia, those who have impending arrhythmias, ventricular ectopic, these patients should be treated with IV even though they harbor mild hypokalemia. That you have to remember. Otherwise, When you have hypokalemia less than 3, then patient should be given IV potassium. But IV potassium, it is 1 ampoule potassium is equal to 20 milliequivalent of KCl, potassium chloride. That you have to remember. So generally we prefer potassium chloride as an IV form to correct hypokalemia. Generally, in the peripheral line, potassium chloride can be given only 10 milliequivalent per hour. That is very, very important. If you want to give more potassium chloride, then you have to choose central line. That's very, very important. In the peripheral line, the potassium chloride infusion can't be exceeded 10 milliequivalent per hour. That's very important. Then apart from that, when you have this kind of resistant hypokalemia, then what will you think? What is a hidden electrolyte disorder which is responsible for resistant or recurrent hypokalemia? When you have resistant hypokalemia, when you are not able to correct potassium depletion, even though you give enormous amount of potassium chloride, then you have to think of one important associated electrolyte disorder, that is nothing but hypomagnesemia. So please remember that hypomagnesemia can produce hypokalemia. So what is the relation between hypomagnesemia and hypokalemia? When you have hypomagnesemia, what happens? The potassium channels that are present in the thick ascending limb of loop of Findlay in the kidney are not functioning properly. When you have hypomagnesemia, these ATP dependent channels or magnesium dependent channels that are present in the thick ascending limb of Findlay are not functioning properly, resulting in potassium wasting in the urine. That's why you have to correct hypomagnesemia when you have resistant hypokalemia. But please ensure that serum magnesium level is depleted when you try to correct resistant hypokalemia. So what is the normal magnesium level? So normal magnesium level is 1.4 milliequivalent to 2.4 milliequivalent. Generally hypomagnesemia commonly seen in alcoholic individual. Almost 30% of alcoholic individual develop hypomagnesemia due to poor intake and renal magnesium wasting and so on, many reasons. Then apart from that, it may be due to diarrhea. And what you have to remember, the diuretics. So diuretics can produce hypomagnesemia and hypokalemia as well. These are the few causes. But generally magnesium sulfate would be the ideal choice to correct hypomagnesemia. When you have hypomagnesemia, especially less than 1 milliequivalent, then probably you have to choose magnesium sulfate. Based upon the severity, magnesium sulfate infusion can be varied. For example, when somebody has torsidicity point is secondary to hypomagnesemia, I mean the ventricular worst form of ventricular tachycardia, polymorphic ventricular tachycardia, where magnesium sulfate can be given 1 to 2 gram, can be given over 2 to 5 minutes, or otherwise it should be given 15 minutes. But in asymptomatic severe hypomagnesemia, you can give just 1 to 2 gram of magnesium sulfate can be given over 1 hour. So the most important highlighting point here is when you have hypokalemia, despite treating with hypokalemia with oral potassium supplementation or IV potassium chloride, still hypokalemia is not correctable, then think of hypomagnesemia and find out the cause for hypomagnesemia, treat hypomagnesemia with magnesium sulfate based upon the severity. Thank you.